Hi, everyone. Welcome back from our intermission. Up next, we have our final guest speaker, Dr. Roman Palitsky. Dr. Palitsky is an assistant professor of psychiatry and behavioral sciences and director of the research projects in spiritual health at Emory University and is faculty in the Emory Center for Psychedelics and Spirituality. His research applies a biopsychosocial spiritual approach to improving behavioral interventions by ensuring that the treatments we offer are responsive to care seekers' cultural needs and strengths. His work in psychedelic treatment research reflects these commitments by seeking to make psychedelic therapies rigorous, effective, and accountable to many patient populations who might benefit from them, and to support those care seekers who may experience adverse effects. His presentation today is titled Navigating Adverse Events in Psychedelic-Assisted Therapies, Conceptualization, Assessment, and Patient-Centered Response. Let's all give a warm welcome to Dr. Palitsky.
Hello, can everybody see my slides?
Yep, you're all good.
Okay, great. I always want to double check, and it's my slides, not the presenter view.
No, it's just your slides.
Great, fantastic. Thank you for that introduction, and sorry that introduction is a little bit of a mouthful. But yeah, today's topic, what I really looking forward to talking to all of you about, and I'm so pleased to be here at the Intercollegiate Psychedelic Network to talk about adverse events in psychedelic therapies. And specifically, I'll be talking about work we've been doing to conceptualize adverse events, how we're working to assess them, and how we've been thinking about developing patient-centered responses to adverse events and adverse effects of psychedelics when they do occur. So all of this work, I just want to give a bit of a plug to the Emory Center for Psychedelics and Spirituality, which is where a lot of this work is coming from. And ECPS, or Emory Center for Psychedelics and Spirituality, is a relatively new fledgling center. However, we've done a lot over our almost 2 years of existence. We have over 20 faculty across a range of disciplines that include investigators working in cellular biology and investigating senescence and molecular mechanisms, as well as historians, philosophers, and scholars of religion and the humanities, and of course, many psychiatrists and psychologists as well. And my training is in clinical psychology. My focus as a clinical psychologist is in behavioral medicine and in cultural and existential issues as they arise in therapies. I also have a Master's of Divinity, which had focused on the anthropology of religion primarily. So alongside my roles at Emory as Director of Research Projects at Emory Spiritual Health and Assistant Professor in Psychiatry, I'm also really privileged to be faculty affiliated with ECPS. And what I'll be talking about today is really related to that part of my work. So at ECPS, I tend to think of my work as falling into three related buckets. The first of these is the spiritual, existential, and religious and theological dimensions of psychedelic care. The second is the optimization of psychotherapeutic components in psychedelic therapies. And the third is understanding, measuring, and addressing adverse events as they occur in psychedelics. And that's the part that I'll be talking about primarily today. So before going into my own work and my work with colleagues at ECPS, I'll first kind of zoom out a little bit to discuss the state of the science on psychedelic-related adverse events. And here, just briefly, what I mean by psychedelics are the classical psychedelics, such as 5-HT2A receptor agonists like LSD and psilocybin, other Schedule I drugs such as MDMA, but also ibogaine, ketamine, and other substances that are culturally recognized as psychedelics. And so I heard the last speaker's presentation about nitrous oxide. And so, there are definitely some blurry boundaries here, but at least those compounds that are kind of culturally known to be psychedelics is what I'm talking about. And the good news is that generally speaking, psychedelics are considered to be safe. So most recently, there was a systematic review by Romeo and colleagues that found generally a low rate of adverse events. We have now kind of a seminal study by Matt Johnson and colleagues from 2018 that did a review of potential for harm either to oneself or to others based on various substances of abuse. And we see all the way on the right side of their bar chart the psychedelics, which seem to have relatively low abuse potential. And from clinical trials, we see serious adverse events reported at low rates. Just last month, we had another study, a review published in JAMA, that found that the therapeutic psilocybin's adverse effects were mostly resolved within 2 days. So that's pretty good news. And diving into some of the clinical trials, we find sort of commensurate results. So briefly, just for definition's sake, when I say adverse events and serious adverse events here, I'm relying on criteria that are used by HHS and NIH and other entities. There tends to be agreement. Adverse event would be any abnormal sign, symptom, or disease temporally associated with the subject's participation in research, whether or not considered related to the subject's participation in the research. So in other words, if something negative or untoward happens while a person is in a study, whether or not it is deemed to be caused by the study, it needs to be reported as an adverse event in most cases. And serious adverse events are a sort of a higher tier, higher acuity range of adverse events that can include risks to life or risks to permanent damage to the patient or participant. And those usually need to be reported right away. So from clinical trials, we have evidence from 2 recent phase 2 trials of psilocybin. In 2023 from the USONA study, and found 76% of patients reported adverse events, and serious adverse events were reported at 8%. In the prior year's publication of the COMPASS phase 2 trial in the New England Journal of Medicine, adverse events were reported among 84% of participants and serious adverse events in 10%. Now, notably, there was also an observed increase in suicidality related to those, which we can talk about later. That's in the clinical trials of psilocybin. Recent phase 3 trial of MDMA observed equivalent rates of psychiatric adverse events in MDMA versus placebo groups, although there was a higher rate of physiological adverse events in the MDMA group. So these rates are fairly confidence-inspiring, and given the pretty powerful effects of psychedelics, people regard these as often tolerable rates of adverse events. So that's the good news. Now, here is the rest of the news. And I'll be turning to I think, a very informative review by Breeksom and colleagues from 2022, where, again, they reviewed all the trials that had taken place up until then. Again, they observed low rates of adverse events, but they suggested that this is very likely to be an undercount. And there are several reasons for that. One is that historically, we are getting better about this, but historically, clinical trials have relied on an approach called passive monitoring. And what that means is that participants are not specifically probed for known adverse events, but they're just asked, did anything negative happen? And if they can think of something to share, or if they know of something negative that has happened, they'll volunteer it. But we know from research in other treatments that passive monitoring tends to underestimate adverse event rates. Patients are likely to not report a range of negative effects, and that undercounting can be up to 22-fold in some cases. We also know that there's low frequency of adverse event assessment and very little follow-up assessment of adverse events in clinical trials. We tend to focus on a relatively short frame of time. And specifically, we tend to focus just on the acute dosing experience. So when we saw that recent review published in JAMA, that the adverse effects of psilocybin typically resolve within 2 days. These are just the acute adverse events associated with psilocybin, rather than adverse effects occurring in the days, weeks, or months following psilocybin use. And yet that is where we tend to look when we want to see the positive effects of these therapies. Adverse event assessment struggles from non-systematic assessment, which means that different trials at different time points with different populations will use different measures for evaluating adverse events. And that makes it very difficult to aggregate and integrate measures of or assessments of adverse events and counts of adverse events across studies. And finally, this issue, and I'll be spending most of the rest of our time today talking about this last issue, which is that they tend to suffer from restricted criteria. Psychedelics are kind of an unusual treatment in that they don't just elevate mood on its own, for example, in depression. They tend to do a lot of other stuff, and that other stuff is important in the acute experience. So effects on worldview, effects on relationship, effects on connectedness, right? These are more than just the aspects of acute physiological and acute psychological experiences. So looking at the Compass Pathways study published in 2022, that phase 2 trial, this is their list of adverse events from that therapy. And what we see is a set of predominantly physiological adverse events or acute psychological adverse events that don't extend to things such as worldview, such as ego dissolution, which we heard about in the last talk. They're really just, it's a small lens on adverse events. And in the subsequent Usona study, we actually see them acknowledging this. Psychedelics may produce adverse events not captured by standard rating scales, or may induce unrecognized new psychiatric conditions, even as they improve target outcomes. This last piece, I also want to pause on. It's not a zero-sum equation where we have either adverse events or benefits. It is entirely possible to benefit from a psychedelic therapy and to experience an adverse event. And this is true of other therapies as well. We know this from headache medications, from chemotherapies, from really any therapies with any risks, that individuals can experience some of the negative side effects even as they experience the intended benefits from the therapy. Outside of clinical trials, we also have a little bit of research that I'll get to in a little bit. But we also have this a little bit of cause for concern, even in well-designed clinical trials, even the ones that seem to be the most recent and doing the best job of clinical reporting. I'll turn here to a report from the Institute for Clinical and Economic Review that evaluated Lykos Pharmaceuticals' recent application for rescheduling of MDMA to the FDA. And I'll just draw on a few concerns raised by this report, specifically in the areas of adverse events. So one is, we repeatedly heard about, and I just highlighted the relevant portions here. We repeatedly heard about pressures to have the results of the MAP trials be favorable. So this is based on conversations with participants of the Lykos and MAPS trials. This led to some participants feeling pressured to report good outcomes and suppress bad outcomes when they were in the MDMA arms of the trials. Additionally, for those who were part of the community, some participants felt they could be shunned if they reported bad outcomes, or that it could lead to future patients being denied the benefits of MDMA-assisted psychotherapy. We heard that positive reports generated positive feedback and negative reports generated negative feedback. We heard that this is a particular problem in people receiving MDMA, as it makes them particularly suggestible and susceptible to context. And here's another excerpt. We heard firsthand and secondhand reports of extremely severe negative outcomes for participants in the trials that do not seem to have been attributed to the treatment by the trial researchers. Some patients were told by their therapist that their negative outcomes were evidence that they were responding appropriately and would eventually improve. Some patients were prevented from entering the long-term follow-up study and felt this was done to keep these negative outcomes out of the dataset. So these are very serious concerns and really raise the priority of adverse event assessment. I also want to note that a large group of clinicians and researchers involved in the Lykos trials have authored a very thoughtful and thorough response to these concerns. It's definitely not my intention here to adjudicate these challenges, but I do think that a takeaway is that participants experienced adverse events that were not captured, and this is something that we should not allow to take place in psychedelic research or in psychedelic care. So I mentioned before, outside of clinical trials, we also have some data on adverse events. So this is a study by Simonson and colleagues, where among 632 individuals with experience of psychedelics, approximately 60% reported no challenging experiences, which is really good. 9% reported functional impairment that lasted greater than a day, and 2.6% of those sought medical, psychiatric, or psychological assistance after their worst experience with psychedelics. And so we don't know if there were other occasions. They only asked, after your worst experience, did you seek medical, psychiatric, or psychological assistance? So if we just do a little bit of back of the envelope map for this, we know that, and this is likely an underestimate, but at least 22% of adults in the US have tried psychedelics. The US adult population is 258 million adults. So we multiply that by 22%, and then we take 2.6% of those, and we arrive at 1.5 million adults, if these results are generalizable, who would have sought medical, psychiatric, or psychological assistance after their worst experience. And these numbers are likely to go up. So we know that Poison Control Center calls for psychedelics have tripled between 2018 and 2022. And emergency room visits and hospitalizations increased by approximately 50%, related to psychedelics, increased by approximately 50% from 2016 through 2022. So we're in a position where psychedelics, for legitimate reasons, have conjured a great deal of hope. Their use is increasing, standards for clinical care are well underway, and yet we may be missing some crucial safety issues. So I think the next part of my presentation is going to focus on what we've been doing to address these safety issues and to meet the need for adverse event assessment in psychedelic therapies. So to kind of map out the space that we've been working in, the main goal is to establish safe, effective, and responsible practice in psychedelic treatments. And that means being able to evaluate adverse events in clinical trials accurately, and also to develop recommendations based on stakeholders' own experiences. An allied aim is to begin to understand the variety, the nature, the prevalence, and the experiences that go with psychedelic adverse events. So part of this work is qualitative and quantitative research to establish a sort of a clinical footprint of these adverse events. So do adverse events in after psychedelics resemble or in fact precipitate known clinical phenomena such as a manic episode or psychosis or depression or depersonalization, dissociation, or do they represent novel clinical constructs that require tailored and specialized care? And the other half of that is moving from adverse events, which is the monitoring of events as they occur, to adverse effects. How do these adverse events end up having real life effects on our patients and care seekers. And together, this leads to having a mature framework for responding to psychedelic adverse effects. So again, this would rely on narratives of patients and care seekers' lived experiences and after adverse effects, well-developed clinical constructs that can help to create therapies, and observational data based on what care seekers and participants do after they experience adverse effects, in order for us to understand better what helps and what doesn't in order to resolve these symptoms. So taken together, we're hopeful that this can lead to treatment development. On one hand, better psychedelic therapies that can prevent adverse events from occurring, and when they do occur, having treatments and interventions that can reduce the duration or severity of adverse events. So I'll focus now on adverse event measurement in clinical trials, which is something we've been taking a lot of time to develop and evaluate. In fact, over the last approximately 2 years, we've been developing a model to characterize those adverse events that appear to be relevant and reported in psychedelics across the literature and also based on informant reports, but which seem to be missing from adverse event assessment in clinical trials. So one area actually that doesn't seem to be missing, and I just want to name this, is the typical standard adverse event assessment that we see in pharmacotherapy research. So this goes back to that set of adverse events from the Compass Pathways trial. And these rely typically on something called the MEDRA, the Medical Dictionary for Regulatory Activities. It's a very well-known, well-organized, well-developed system across 27 system organ classes with over 76,000 lower-level terms for specific adverse events that can happen. And we think that that actually does a pretty good job in monitoring the sort of standard things that can go awry in a typical pharmacotherapy trial. So it's pretty good at measuring physiological changes. It's pretty good at picking up on things like increase in depression, increase in anxiety. But there are some things that these existing systems don't appear to be well tailored to pick up on. And part of the reason for that is psychedelics are kind of a novel set of treatments. They behave differently from Prozac. They behave differently from, sorry, I'm going to pause. I see a comment. Oh, what do you think about the maxim that bad trips are healing trips in disguise? Yeah, we'll definitely talk about that as we keep going. Thanks for that question. It's a good one. So, which maybe ties into this next piece. Psychedelics have these very unique effects. One, psychedelics tend to influence patients on the level of worldview, on the level of their spirituality, their existential perspectives, their relationships, their sense of connection, which and through these really impactful personal phenomenological dosing experiences, which we don't tend to see with any other substance. And the other is that psychedelics are when administered clinically, they tend to be a combination therapy. Right, so we have the pharmacological compound that is administered really intentionally alongside a psychotherapeutic delivery. And both of those can have their adverse effects. So I'm just going to go through a range of 7 domains that we've identified that appear to be typically missed in the pharmacotherapy assessment. If I can get this slide to advance. There we go. So these include sociocultural adverse events, and that can be something like cultural harm, cultural invalidation, or stigma, or strain in relationships with one's community. Behavioral adverse events, such as increase in problematic substance use or social withdrawal. affective, cognitive, and metacognitive adverse events, which would include things like ego dissolution that lasts way longer than would be therapeutic and becomes distressing, or epistemic or ontological shock, as it's been described, changes in one's relationship with the world or with belief in the reality of one's thoughts. Psychospiritual adverse events and psychotherapy-related adverse events. I'm actually going to devote a lot of time to talking about these, so I'll move on to the last two: perceptual adverse events, which are things like hallucinogen persisting perceptual disorder, or HPPD, flashbacks, reactivations, or interpersonal adverse events. So adverse changes to one's attachment relationships or relationships with others in one's life. So we developed, and we're not going to go all the way through this entire system, but through this work, we developed a system for adverse event assessment comprising 54 discrete categories across these 7 domains. And one of the things that we did is we evaluated known instruments for assessing adverse events in psychotherapies. And those are the ones in the legend. You can look up this paper either in its preprint form, or it's just been accepted for publication, and that'll be out probably in the next month or so. But these are different assessment measures that can capture different aspects or different portions of these domains. The X's here they represent coverage of these different specific terms by the different scales. And I just want to pause here and reflect across all of these different assessment instruments. It's really interesting to see which one covered more criteria than anything else. And this is really important and informative for our field. And this was a measure developed to assess adverse events in meditation-related interventions. And it seems like these psychospiritually oriented interventions that change how one experiences the world, such as meditation-based interventions, have a good deal of overlap with what we think is really relevant to psychedelic-related adverse events. So I promised that I would talk about psychospiritual and psychotherapy-related adverse events next. And so that's going to be the next domain I'm going to focus on, psychospiritual adverse events. So to do that, I need to take a step back a little bit, and it's going to be a digression, but I promise we'll get back to psychospiritual adverse events. And that digression starts with kind of a glance at the history of our psychedelic science. So here we are, IPN 2024, and we really stand on the shoulders of about a century of incredibly formative research in psychedelics. Just in the recent year, we had a phase 3 trial of MDMA, several phase 2 trials of psilocybin. In our psychedelic renaissance or psychedelic adolescence, some really important studies of psychedelics for substance use disorders, for distress associated with end of life. Going back before then, we see the Good Friday study, a number of really good and informative studies conducted in the US and in Europe. And going back before then, several decades of generative invention and study of psychedelic compounds, the development of LSD, studying the psychotomimetics of mescaline. Prior to that, a much more extensive history of traditional use of psychedelics that takes up much more time in traditional societies. And that is often how the history of psychedelics is presented. And at this point, I want to invite you to sort of shift in perspective, borrowing from this geological idea of deep time. So in Alden's words, deep time refers to the time scale of geologic events, which is vastly, almost unimaginably greater than the time scale of human lives and human plans. It is one of geology's great gifts to the world's set of important ideas. So if we take a deep history perspective on psychedelic science, a different picture begins to emerge. Again, here we are at IPN 2024, but going back, we see fully 1,000 years ago evidence of ayahuasca use in Bolivia. Approximately 3,000 years ago, evidence of Amanita muscaria use along the Taiga Belt. Almost 4,000 years ago, evidence of Datura use in Andorra. 6,000 years ago, evidence of peyote use along the Rio Grande. In the northern Sahara, based on petroglyphs and pictures, evidence of psilocybin use. And finally, approximately 10,000 years ago, evidence of San Pedro use in Peru. And this is just the observed archaeological record. It's likely that human encounters with psychedelics have gone back much further than that. So why take this deep history view? Now, I don't mean to suggest here anything like a naturalistic fallacy, where just because this is the way that we have been using these substances for a long time, means that this is how we should continue to use them. But if we look back across this history, including our own history here in our brief 100 years of psychedelic science, which is 1/100th of that time span, we are turned onto a set of recurring encounters between human beings and substances known now as psychedelics. And this deep history perspective can help point us toward the nature of these recurrent encounters and a little bit of their structure, maybe. And what they seem to point to time after time is a sense of spiritual significance accorded to these substances. And that continues into the present day in our recent century of psychedelic science. And at this point, I'll introduce an acronym, SIRT, which stands for Spiritual, Existential, Religious, and Theological, which is how we've been thinking about these spiritual and existential impacts of these substances. We often hear about mystical type experiences in psychedelics. And these are these transient but transformational experiences where a person maybe transcends their sense of self, their experience of time is different, they come away with new knowledge and maybe having made contact with something real. And these are really important experiences. I don't mean to diminish them. And yet I find that for the study of psychedelics, we've been turning more and more toward this CERT frameworks. I find it to be more inclusive of the kinds of domains of spiritual and existential life that occur before, during, and after psychedelic use, and can help us to better understand psychedelic impacts, I think. So I'm going to be using the CERT acronym a little bit. And from this last century of psychedelics research, we do have some evidence of the importance of CERT impacts. So here is a small, non-comprehensive subset of studies, like a mini literature review of different compounds for different indications with different populations that all seem to demonstrate a kind of a dose-response relationship, where the higher the psychedelic dosing, the more likely it is that people report CERT-relevant impacts on their lives. And here's another mini non-comprehensive literature review, again, different compounds, different populations, different indications, in which we see that the more people report CERT impacts, the more likely they are to report some benefit from the psychedelic therapy that they were given. And from a clinical science perspective, this looks a lot like something that we would call mediation. Mediation is any time that you have a treatment like psychedelics that changes its outcome, so let's say depression, by affecting some kind of a third variable. And in this case, that third variable would be CERT. So in ordinary psychotherapy, when we see a mediator, it's usually a good idea to make sure that your therapy can address it in some fashion. A common example of this is the therapeutic alliance, or the bond between the therapist and the client. So if you have a therapy, and that could be either something like cognitive behavioral therapy or psychoanalysis, but if that therapy can enhance the bond between the therapist and the client, then that therapy is more likely to be effective. And this is so well recognized that now most therapies build a focus on the therapeutic alliance into the therapy model itself. So looking at this and looking at these CERT impacts, one thing I want to just point out initially is this suggests a mediation model, but the jury is still out. We're still waiting for evidence, largely because of sample sizes, to either corroborate a mediation pathway of CERT impacts or not. But we do know that these experiences are very important for patients and participants in psychedelic therapies when they occur. So we have been working on a map illustrating the different points of contact between CERT and aspects of psychedelic care. We published this approximately a year ago in JAMA Psychiatry. And I'll just kind of spell it out here on the screen. We think of psychedelic treatments typically as a kind of as a package treatment that includes some number of preparation sessions, a dosing session or sessions, and some number of integration sessions afterwards to help patients or care seekers integrate the experience into their lives. And this package therapy is applied to the care seeker. But it actually becomes pretty important to ask who is the care seeker in order to tailor and better understand the effects of these therapies. So at the individual and intrapersonal level, there are a number of factors that can nuance the way that these therapies take effect. And we can think about the genetics of the individual, their medical history, their specific symptoms, but also their beliefs and their personally held worldviews. And these exist within a social and a community domain that might include their attachment and social relationships, their roles within their communities. And these in turn exist within a cultural and a collective domain that includes human geography, history, economics, and culture. Now, I don't think I'm really telling anybody here anything particularly new. We're familiar with looking at treatments in this way. And I want to point out that CERT influences occur at each one of these levels. So when we think of the individual and intrapersonal level, we can consider the beliefs that people have about their symptoms, the spiritual and existential meanings that they make out of their condition and their suffering, and the coping strategies that they turn to. At the social and community level, we might think about the interpersonal and community resources available to our care seekers, as well as the demands that their communities exert on them. And at the cultural and collective domain, we can think about interreligious history. The legacies of collective resilience and trauma that people have lived through, and how these have been impacted by religion and also gone to impact their religious and spiritual lives. So all of these different levels can be included in a skillful assessment in psychedelic-assisted therapies, and we argue that they should. Probably not through a lengthy, extensive questionnaire, but through smart case conceptualization and tailored assessment so that we can identify and address certain risks and vulnerabilities to help support patient safety and also to support their strengths. So ideally, this can help us tailor psychedelic therapies, again, at each and every one of these levels. So at the individual and intrapersonal level, we can engage the care seeker's own understanding of psychopathology and the spiritual and existential meanings that they make of them. We can address and assess and respond to developmental CERT influences. Did they disaffiliate from a religious community? Did they convert? What effect is the psychedelic experience going to have for them and on their spiritual worldviews? At the social and community level, I think this is where ritual becomes incredibly important. Ceremony and other collective rituals can really enlist that source of social support and engagement and involvement. We can also enlist their existing community support and address sources of stigma. And finally, at the cultural and collective level, it's important to bear in mind that none of us are the experts in how our care seekers come to know about the world. And that encourages us to practice epistemic humility. We can also take historic sensitivity very seriously with psychedelic therapies. And I don't just mean historic sensitivity as a kind of a meaningless phrase to support the inclusivity of these treatments, which is really important, but to really assess how serious an influence history can be in the lives of our care seekers. That many of our care seekers wake up into history and live in history. And this is not just an abstract force, an abstract influence on patients' lives, but And there's a reason why it's so important to practice this kind of inclusion. And that is because history affects all of us in very different ways. So you can think about practicing non-appropriative cultural inclusion and support collective resilience among our care seekers. Ideally, all of this can be integrated into the delivery of psychedelic therapies. And coming back, like I promised, to our point about psychedelic-related challenges and adverse events, it can inform how we assess adverse events in psychedelic care. So to that end, we'll go back to the initial slide about psychedelic safety and what we know about rates of adverse events, and to this point of restricted criteria in psychedelic-assisted therapy adverse event assessment. So we recall this mediation-like model where we see the importance of certain impacts for the beneficial effects of psychedelics. Well, what happens when things don't go as preferred? What happens when we experience negative cert-related impacts? And for those who are interested, I'd like to just point you to a wonderful essay by Rachel Peterson called A Theological Reckoning with Bad Trips, published in the Harvard Divinity Bulletin, where she describes in close and moving detail some of these theological and spiritual effects of negative experiences and negative enduring effects of psychedelics. In the framework that we have, that we've spent so much time in developing, we paid a lot of attention to these psychospiritual impacts. So I'll just go through the psychospiritual adverse event criteria. These include existential distress, so distress about loss of coherence, change in meaning or purpose, sense of meaning or purpose, adverse effects on fear of mortality or core aspects of one's existence. Death anxiety, which is an anxiety, it's not a fear of dying immediately, but it's anxiety about being mortal. Personal, religious, or spiritual struggles, which include tension and strain with one's belief system inside oneself, as well as communal religious or spiritual struggles. So strain and tension with one's community, with one's congregation. Experience of having one's spiritual worldview undermined. The experience of spiritual or religious abuse, which can happen either in clinical settings, but also in settings like retreats. And we've seen this occur from individual reports and people who've personally had these things happen to them in clinical and retreat type settings. And religious or spiritual imposition, so the experience of proselytization or having other external spiritual frameworks imposed on the person. The next set of adverse events I want to talk about that we've spent time fleshing out are the psychotherapy-related adverse events. So we know that it's best practice in psychedelic therapies to combine them with some kind of psychotherapeutic support. And increasingly, we recognize the capacity for benefit from that kind of interpersonal support, as well as potential harm. So in a really striking and well-written article published in JAMA approximately a year ago by Sarah McNamee and colleagues, they described it this way. It would be unimaginable for clinical trials using a combination of two drugs to only examine or regulate one of the two components. However, this is the norm in psychedelic research, in which the psychological support is neither systematized nor evaluated as in traditional psychotherapy research. So again, psychedelic therapies are really a combination of these two treatment approaches, but we're only evaluating the pharmacological side of them and not the psychotherapeutic side of them. And yet we know that adverse event assessment that only relies on pharmacology-derived criteria tends to underestimate adverse events related to behavioral, lifestyle, or psychological therapies. We also know that psychotherapies have known rates of adverse events. So in standard CBT, psychoanalysis, exposure therapy type therapies, adverse event rates range between 3 and 7% of patients. And in substance use disorder treatment, these are approximately doubled. A key piece to bear in mind for psychotherapy-related adverse events is the role of suggestibility. So what I mean by suggestibility is the capacity for psychedelic compounds to influence the way that participants experience or understand the world, or to change their beliefs about certain things. And that there's evidence from multiple studies that psychedelics can, in fact, enhance suggestibility. So thinking about this in the context of psychotherapy, we can compare this to what we know about how psychotherapies mold and affect the way that patients experience the world. So this is from a wonderful paper by David Goodman, published in 2016, called The McDonaldization of Psychotherapy: Processed Foods, Processed Therapies, and Economic Class. And in this paper, Goodman describes kind of a case where a patient goes in to see their therapist, and the patient says, well, I've really been feeling a lot of X. And the therapist says, well, hold on a second, X is not really a feeling, that's more like a thought. Here is the difference between a thought and a feeling. Now, can you tell me back what you were thinking and what you were feeling that went along with that, which is a pretty common cognitive behavioral therapy tool. And so responding to this and analyzing this approach in therapy, as Goodman writes, different therapeutic orientations are different languages that human beings have for understanding their suffering, meaning, identity, and healing. Treatment practices and their respective languages carve out the horizons of possible experience. In psychotherapy, the language about my experience shapes, orients, and ultimately mediates my self-experience. So psychotherapy models often have either explicit or implicit views on some very existentially important questions. For example, how does the mind work? What is the relationship between thoughts and feelings? What is real? Are my thoughts real? What is a realistic goal for therapy? What is a realistic thing for me to want? Who am I? Am I a unified being, or am I made up of different parts? Why am I suffering? What contributed to my experience of distress? And what does my suffering mean? So all of these have tremendous existential and personal relevance. And I think we're only beginning to grapple with these issues in psychotherapy, primarily in the areas of culturally competent care. But I anticipate that these are going to be extremely important to address in psychedelics. So when we talk about suggestibility in psychedelic therapies, I would argue that the suggestibility does not begin when a person takes the psilocybin or the MDMA, but that it begins when a care seeker shows up at the door and says, please help me with a problem that I've been having a hard time managing on my own. And they put their experience, at least in part, into the hands of the clinician. So in our framework for adverse event assessment, as we fleshed out psychotherapy-related adverse events, we paid particular attention to these issues. So what we've basically done is we've synthesized things that have been known to come up in psychedelic therapies, as well as known challenges, known adverse events that can affect regular standard psychotherapy, and brought all of these into our framework. So we cover psychotherapist relationship strains, so damage to the therapeutic alliance, feelings of betrayal by the therapy team, excessive or inordinate amount of dependence on the therapist or therapists, feelings of abandonment by the therapist or therapy team, therapist abuse or exploitation, which includes coercion, manipulation, exploitation, inappropriate touch of any kind, and then specifically sexual contact between therapist and care seeker. Heightened concern about symptoms. So this can occur in psychotherapies when a person presents with symptoms that didn't used to concern them very much, but as a result of the therapy, they now become preoccupied by them. And in psychedelics, this may be especially important, loss of confidence towards interventions. So if psychedelic therapy is presented as a treatment of last resort, and a person has tried many other treatments, what happens if the psychedelic therapy does not help? Do they lose confidence that they can be helped at all? So taking this framework and moving forward, the next thing I'll talk about is sort of what we're planning from here on forward, sort of next steps in taking the measure of psychedelic adverse events. So going back to this kind of triangular model, the next piece I'll just briefly describe is our work to understand the variety, nature, prevalence, and phenomenology of psychedelic adverse events. So I wish that I could tell you the rates, the importance of these adverse events, and how long they last. But in fact, we don't yet know any of this because these adverse events haven't really been studied. We do have several projects in the works that will hopefully address that. So maybe in a couple of years, I'll be able to come back and tell you the incidence and prevalence of these adverse events. So right now, our framework is currently being applied in 2 psychedelic trials and 2 planned psychedelic trials, and we anticipate many more. But we also have yet to translate from adverse events to adverse effects. And that's to say we don't really know the clinical footprint of these events, which means that we treat them with tools that have typically been developed from other contexts. So either psychiatric contexts or meditation contexts or spiritual contexts. In order to develop tailored tools, we need to better understand the phenomenology, the symptoms, the duration, severity, and clinical syndromes that accompany these adverse events. So guided by a set of principles that I'll enumerate here, we're taking the steps to get this specific type of data. So we're hoping to capture adverse events in a way that is user-informed, that is standardized in a way that's replicable from context to context, that's based on the impact of these adverse events. So do they contribute to distress or impairment? That doesn't have either cultural bias or bias in the language around positive or negative effects of specific phenomenology. So is ego dissolution a positive or a negative thing? Well, probably both, and it would likely depend on its impacts. So we want to be able to measure ego dissolution without interpreting it to be either positive or negative. We want it to be detailed and excluded from psychedelics research, and that includes BIPOC individuals and participants, as well as people who are not psychedelic advocates from the beginning. We want to be able to assess the factors that influence impacts and trajectories of psychedelic adverse events, and that will require longitudinal assessment of adverse events. So to do this, we have a study that is currently in the setting up and planning stages that includes the validation of a detailed measure of psychedelic-related adverse effects, which would then be applied longitudinally for approximately a year to follow individuals who've experienced adverse events across 12 months. And by recruiting individuals who've experienced adverse events within the last 3 months, last 6 months, last 9 months, and 12 months, over that 1 year time frame, we hope to actually be able to capture 24 months worth of adverse event trajectories. In that assessment, of course, we're going to be measuring risk and resilience factors and factors that influence the trajectories that people experience. Finally, in our work to understand how to respond to psychedelic adverse events, I'll just briefly mention a study that's going to be launched in the fall. And this is a study that is set up to identify optimal responses to challenges in challenges in psychedelic therapies. And we're calling it the dial-in study. So this is going to be happening within an ongoing trial of psilocybin for major depressive disorder with 141 participants. And what we're going to be doing is, on top of this trial, we're adding a very fine-grained suite of measures. We're going to be doing ecological momentary assessment, so asking people 4 times a day, every day, a series of questions about how they're doing for a total set of 28 days, 14 days before and 14 days after psilocybin dosing, as well as during a period at 8 weeks. Part of that EMA assessment is going to include a voice diary so that participants can tell us in their own voice what they're experiencing using their own terms. It also includes personalized items. So in addition to our pre-existing, pre-created measure, we're going to ask participants to tell us what it is that they think is most important to measure. And we're going to be measuring that in the EMA as well. We're also going to be using a technology called the electronically activated recorder, or EAR, to measure ambulatory audio during a small portion of participants' lives, but which can representatively give us a catalog of their recordable behaviors assessed through audio. So this is going to be for 3 4-day periods during the trial, where we're going to get to actually go beyond self-report and to see how behaviors by the participants, but also from the people around them, tend to impact their trajectories after psilocybin. So the purpose of doing all of this is to better understand what happens if somebody has a challenging or a negative experience shortly after psychedelics, after a psychedelic experience, and in this case, psilocybin. There was a question in the Q&A of, well, how do you know whether this is a growth experience or whether this is an adverse event that requires remediation? And we think that the answer to that question is likely to be quite complex. It's not yet well understood, but by assessing what happens after a challenging experience, we can identify the factors that contribute to either a trajectory that leads to growth and improvement versus a trajectory that leads to decompensation, worsening, or deterioration for the patients. One of the things we're doing in this study is we're using an approach called complex dynamic systems modeling to evaluate these trajectories of response to psychedelics. So what we're thinking is that in general, people kind of have a stable system of responding to the world, responding to stimuli, which can be quite healthy and helpful. But in psychopathology, this can be how a psychopathology is maintained. One of the things that psychedelics are known to do is they can destabilize that system. And that destabilization can allow a person to create new connections, to form benefits, to expand their repertoire of response. But also when the system is destabilized, it can contribute to worsen it because you can create a new and arguably less adaptive system. So by being able to detect those moments when the system destabilizes and to identify the environmental predictors and personal predictors of direction that people take after this destabilization induced by psilocybin, we're hoping that we can better understand what is it that contributes to growth versus challenge after psilocybin, and thereby find ways to support those people who need the additional support. So that is my full presentation for today. We have a little bit of time for questions and comments. I'm going to stop sharing my screen, but if you would like to contact me and with further questions, further concerns, you just want to talk about collaboration or research, please feel free to do so. I also want to thank the folks at the Emory Center for Psychedelics and Spirituality and collaborators from many other parts of the academic and non-academic world.
Thank you, Dr. Palitsky, for that informative talk. We do have a bit of time for some questions. So one of the questions we have is, how do you envision actionable ways to incorporate spirituality into psychedelic research and assisted therapies? So for example, like the inclusion of chaplains on the research team to help provide spiritual support. What are some ways this is being addressed?
So this is a really important question to me and to our team here. What we have been doing at Emory is we've actually been working with a model that we've been calling the triad model. And I didn't have time to talk about that today, but triad really stands for a mental health clinician, a spiritual health clinician, and the patient, who are envisioned as a kind of as a triad or triangle, equal collaborators in the therapy. We find that based on the evidence, many mental health clinicians often don't receive high quality spiritually integrated care training. And yet this is a domain where spiritual health clinicians or chaplains receive exceptional training. And a lot of their training goes into issues of non-imposition and of respect for patients' autonomy. So we have found that this sort of this alliance between spiritual health clinicians and mental health clinicians and patients has been really appreciated by patients in the clinical trial context. We also, there was a paper published this winter by Caroline Peacock and colleagues that examined the role of chaplains or spiritual health clinicians in psychedelic therapies, and it describes the various ways in which chaplains bring value added to the treatment process.
Thank you so much. We'll be moving into our student presentations, but again, we really thank you for being here and sharing your knowledge with us. I'm really looking forward to reading your paper and excited for the projects you have in the works. So thank you.
Can I say one more thing as we sign off?
Yeah, definitely.
In the coming year, we will be also interested to collaborate or work with or hire people who are either post-bac students or people at the postdoc level in some of the trials that I described at the end. So if folks are interested, please feel free to reach out to us.
Thank you so much for being here.
Okay, so up next, we have our second and final round of student talks. Again, please enter your questions for the speakers using the Q&A function, and they will be answered during our Q&A session at the end of the day.